Whenever the heart doesn't pump the way it was made to pump, due to problems from the body exerting pressure on it, or because it has been injured through an injury or through an MI, the consequence is going to be heart failure. What heart failure is the definition that they say here is where the pumping of the blood to sustain all the metabolic needs of the body is insufficient, and it's due to cardiac insufficiency. This is then called heart failure. At one time, and for the longest time, it has been called then, because it affects not only the systemic but the pulmonary, the lung area, that this was then called congestive heart failure. So yes, you may still see CHF being used, but in essence we call it now just heart failure. You do need to know forever the signs and symptoms of right-sided heart failure and left-sided heart failure. Now, the body releases hormones, and these hormones that are going to have a negative effect on the heart are going to be your sympathetic, or your epinephrine, and your norepi. These are out there to increase blood pressure. And by increasing blood pressure, they increase constriction of the vessels, except for the coronary vessels and the lung bronchi. So they vasoconstrict everywhere else. They dilate the coronary arteries and the bronchi within the lung. But this puts the ailing heart in a predicament where it can't keep up with the effects of those two drugs on it. This means that circulatory congestion and other mechanisms are going to occur. I'm going to ask, this class is one of the worst here for keeping this door open. It doesn't do any good on hot days to try and cool off this room when we still don't have air conditioner up here working the way it's supposed to. So please keep the doors shut so that when you do come back in after your lunch periods and breaks, it's cool in here. Or else when I'm gone, I mean, I've been trying to get this fixed for 2 weeks. Who knows how much longer it's going to take to get it fixed. Okay, and I'm hot. I'm feeling hot air. So I changed it a little bit, but I don't think it'll work. Is that a phone?
That's my alarm. Sorry.
Oh, sorry. I'm going, holy cow. Alrighty. Somebody's whistling. Okay. Heart failure can occur from an MI or prolonged hypertension, diabetes, valve problems, infection, hyperthyroidism because the basal metabolism rate is up, so that causes a tachycardia, anemia, too much fluid replacement.
Would that be replacement like through an IV?
Through an IV, most certainly. Speaking of which, I'm not speaking of IV, but on the break that we have, These people need to go down and make an appointment with Edith. You are not, your financial aid is not set up for the second part of this class. All right? And if you're not set up with your financial aid, then it becomes your problem to pay off. So I would highly suggest that you go down and make your appointments with Edith and keep them. So, Celia, Alicia Gonzalez, Alicia Guerrera, Addie, Susan Holmes, Laura Donna Johns.
Not with us.
Okay, fine. Na Miniette. Did I say it right?
Yeah.
Oh, okay. Matthew McKay. I want to say McConaughey, but it's McKay. Vanessa Marino. Eva Orozco. Jaquita.
Jay.
Kita. Jay. Kimberly Roach and Madeline. Yes, Madeline. Got it. Oh, if you've already done it, great. This is what I got the other day, last week, and she still needs people to go down there and make appointments. So if I said your name downstairs at break, make those appointments and keep them, or you won't have the funding for your second year, okay? Pardon?
Go now.
At break, please, break. All right, also, on the 25th of June, there is a blood drive. If you do come in, I think I've already did I tell this class, I'll give you makeup hours for theory. Still have to check with clinical to find out if you can use them towards clinical. Usually it's 4 hours, so 4 hours for either. But don't assume that it is sanctioned by clinical. It's sanctioned already for theory, but make sure, and I'll try and make sure that I double check with them out there tomorrow, which you won't know anything about because you're only here today. But anyway, to find out whether or not it was good for it. Don't assume it was. Many of you have badges that are going to run out of date.
Yes.
Matthew, do you have paper? Who has paper to start? Okay, let's start a paper going around. I'm almost done.
Okay.
I know. Let's start a paper going around. If yours is going to run out before you graduate in 2015, you need a new badge. We need your name. At the end of term 3, this is the last of the messages. You will be a year being here. You then have 3 more months. Unfortunately, your TB tests and your chest x-rays will need to be done again. If you do it before your TB test, before 1 year, that means your last one was done. If you get another TB test before then, you only have to get 1. All right? Chest x-rays, for those people who had to get chest x-rays the last time, that applies to you too. So, they will start bugging you at the end of term 3 for that, getting it. I'm letting you know at the beginning of term 3 so you can get prepared and maybe get that one towards the end or the middle. Remember, I'm going to be gone till August, then I'm here for August, and then I'm gone for a couple of weeks in September, and then you're going into term 4. So, please, get it done. Pardon?
I have a question. When we get it done, who do we turn our paperwork into?
Me.
Okay.
Hold on to it until I get back if I'm not here. Don't give it to the girls at the front. They will get lost. And when you do turn it into me, you get a copy of it for yourself. I'm done. I'm going on. Don't touch it. As she goes. Okay. Whack. All right, getting back. You got all the messages, right? All right.
Leslie, I I want to share something. That's why I came over there.
Oh,
The thing is, last time I did my chest x-ray and the PPD and they lost all the paperwork. And when I was in the orientation, they wanted me to do again and I told them Kaiser won't allow me to do again because of the insurance. So I don't know if I go with their doctor for the next time.
no, well, it'll be a year. You need to have one every year.
Yeah.
So
October.
Kaiser will
Provide it.
authorize it for you. Yes,
In October.
yes. All right. Left ventricular failure. This means that the left ventricle here is unable to pump blood out to the rest of the body. If there's been an injury here, it pumps into the aorta. If it is unable to pump due to an MI, due to hypertension, due to peripheral vascular, due to whatever, it is going to only be able to pump so much of the fluid that it has in here out, and the rest is either going to sit there and prevent then the left atrium for dumping in more blood that's coming from the lung, and all it's going to do is back up. And as it backs up in the capillary system, it's going to seep out into the interstitial area of the lung. As that pressure builds up, that pushes then this fluid into the alveoli, making it pulmonary edema. Left-sided heart failure signs are crackles, wheezes, shortness of breath, or dyspnea. Anything that is lung is left-sided heart failure. When we're talking about the heart and heart failure, all right? Eventually, this buildup of fluid that's causing pulmonary edema is going to become life-threatening. That is why your first sign and symptom is going to be listening to the lungs or maybe seeing some shortness of breath. And the way you know that it's sort of shortness of breath maybe is an increase in the respiratory rate. Okay? And it talks about here that it's going to cause pulmonary congestion. Fluid is going to leak from the engorged capillaries into the air spaces. Pulmonary edema is going to occur. We may also get, because there is a problem going on in the lung, you learned in respiratory that a lung problem can then cause a problem out here in the pleura. Some of this fluid may seep through the lung and in here and cause a pleural effusion, which you get enough fluid in there, it restricts the ability for the lung to take a deep breath and breathe. Another classic hallmark sign, but it is more or less a late sign that you need to know, is pink, frothy sputum. Now, a lot of times they will put this classic hallmark sign down as one of the signs and symptoms for left-sided heart failure. But before you get to that, because this is really, really a bad sign because it's constant and you can just stand there and suction the whole amount of time and it is just foaming, foaming, foaming. And they're in a lot of trouble and their blood pressure is dropping, their respiratory rate's going up, their heart, and it's just a constant battle when they get there. So please be aware of it. If there has been injury here, we suspect the worst complication to occur is going to be heart failure. And that's either going to be, maybe it started off with right-sided, but left-sided is death if we don't do anything about it. Now you need to know these signs and symptoms, and you need to know them for other words to be used in the place thereof. Right-sided heart failure. This means that the right ventricle has been unable to effectively pump, maybe against lung pressure due to a problem in the lung. That was then called cor pulmonale when the right ventricle would get bigger for that. It will result in blood backup if the right ventricle isn't able to send its blood to the right side and the left side, right side and the left side. It will also begin to build up, and the right atrium is prime for having it go straight up into this vascular system of the neck. So right-sided heart failure is going to be JVD, jugular vein distension. That is probably one of your main signs and symptoms. Only when it's significant right-sided heart failure. One of your maybe earlier signs and symptoms that you're noting before you note this may be the edema of the extremities. And it's pitting edema. They may also, because right off of here is the inferior vena cava, and the liver right here puts the blood back into the vascular system right there below it going into the heart. It's detoxified all the blood from being absorbed through your GI tract, because it goes there first in order to be detoxified. Then it gets dumped back into the circulatory system. If we have back up here showing JVD and way down here extremities, then it's also going to back up into the liver. And what we're going to see then is liver problems, i.e. one of those is ascites, hepatomegalia, hepatomeg, all right? Enlarged liver, ascites. Because of the enlargement of the liver and malfunction, we may see, that's going to take time, because of this, esophageal varices. Your book here talks about that. So the venous blood is going to be reflected back into the systemic circulation. You're going to see it in peripheral edema. The edema is going to look dependent. Dependent edema is the vascular venous system not working correctly in moving the blood back to the heart. In other words, going upstream. When you go to Bakersfield, if you ever go to Bakersfield over the mountains there, as you come back, you see the water being pumped to LA County via this canal with these walls moving upward in an upward motion, moving water that same way. That's how our valves work, by continuously moving. And if you have problems with that, then it doesn't go up. The water or the fluid, blood sits there. As the blood sits there, the plasma is going to seep out and cause dependent edema. Classifying the staging of heart failure. I would know heart failure. Minimal, mild, moderate. I would definitely know severe. Severe being the patient can't perform any activity without discomfort. They may have angina. They may have LOC problems. It's at the bottom of 333 in the box 8-2. In older adults, you need to write this down because you need to know it. In older adults, because they have a decrease, and we learned that for right now, they have a decrease in cardiac output, don't they? If we tax that with more fluid than what they are used to, i.e. giving them IV fluid after surgery or in the hospital, if you let that or you put it on the pump at a higher rate than what it was supposed to, and we give them too much fluid, they can go into fluid overload. So the concept there is, in older adults, increased IV infusion can cause heart failure. So I would assume that the question is probably going to be like what? Anyone have an idea? What can happen to the patient who's elderly receiving IV fluid?
Blood pressure is going to be high.
Heart failure. Yeah, blood pressure is going to be high because it's trying to pump it, and your answer is heart failure. I didn't give you the question, but I would imagine that that's probably how it's said. But it's similar to what I talked about here, but it's not exactly the way I said it. Now I've sort of said it in a way that probably that question's going to be asked. So you need to, okay, did I just confuse you?
Yes. You lost me at older adult?
Yeah.
In older adults,
Thank you.
increased IV infusion can cause heart failure. I was asking, do you think that that's the way the question's going to be asked? No, because that's the concept that you already have in your mind. It's probably going to say, an elderly patient's getting IV fluid, what is the complication? Heart failure. It's not going to be hypertension. I mean, that can cause, but the complication, real complication, is going to be heart failure because you know the concept. Now, I don't know if that's how the question reads, but I bet you It's not going to be like how I gave it to you. All right, page 334. We're going to see edema in the supine area, in the feet area, in the ankle area, in the thighs, in the genitalia, in the lower trunk. This edema is a bit different than dependent edema. Do you see that now? It's because it is just backing up, backing up, backing up. It's not because they are laying down or standing up that they're getting it anymore. Decreased cardiac edema output. Signs and symptoms. At the very beginning, fatigue. My husband gets very fatigued. He gets some wheezing. So what sided heart failure is he in?
Left side.
Left side, that's right. He hardly ever gets any edema, pitting edema, nope, none. His first signs and symptoms are wheezing and feeling fatigued, feeling really tired. And probably his first sign is fatigue. Then the wheezing comes in. He's not hungry. He doesn't void as much, so he has to take the heavy duty, and he's gained 2 or 3 pounds overnight. So he's been voiding the same, he thinks, but in actuality, he's taken in either too much salt, which retained it, or he's drank too much fluid and hasn't gotten rid of it with just his daily Lasix dose. So he has to take a heavier duty diuretic and follow it up with replacing the potassium with the potassium pills because it lowers his potassium. And this is what this talks about. It talks about that if you gain 2.2 pounds, that's a liter of fluid that you have hanging around 1,000 cc's in your body somewhere that needs to be gotten rid of because it is causing left-sided heart failure, pulmonary edema. All right, assessment. Dyspnea, orthopnea. This is where it talks about the difference, an abnormal condition in which a person may sit or stand to breathe deeply and comfortably. Paroxysmal is the sudden awakening from sleep because of shortness of breath. How do we objectively find this? It's the number of pillows required to breathe comfortably.
Vanessa in the class?
Who?
Vanessa?
Why? Vanessa? What are you doing here?
I got done with all of these.
What's that thing hanging on your side?
Call the bully.
Okay, who's Frank to you? He was one of my students, and his sister and his mother,
Yeah.
they've all passed. Does he look like that when he goes to work as an LVN?
No.
Holy cow, he looks like, oh my God, I'm not even gonna go there what he looks like right now. Oh, boy, is he, and boy, he's lost respect. You better tell him that he's in trouble with me next time you see him. Huh. Coming into my class is Vanessa here. I've taught all of them, and they all passed, okay? So I'm pretty doggone good. All right. Especially for Frank to pass.
Oh, boy.
I'm sorry. All right. Number of pillows, abdominal girth, weight gain. In the box. Signs and symptoms of heart failure. You need to know the difference between left-sided and right-sided. Know them. I've put them up there. You can't forget them. There are so many questions on your exit exam that refer back to this. Left-sided and right-sided failure. Okay, diagnostic tests. Yes, we're going to get an EKG. This is going to show us if there's any damage within the heart from an MI or from hitting the steering wheel and causing pericarditis.
An EKG?
EKG or an ECG, they're both the same. Okay. They may do a cardiac cath or a MUGA. The MUGA is going to tell them what the ejection fraction is. Ejection fraction means how much blood, how much muscle is functioning to eject the blood that is coming into the heart. We should be above the 75 with a nice, good heart. After an MI, it's pretty good if you're at 50%. But once you get down to 30%, we're in trouble. That means that the muscle of the ventricles are not pumping very well. And this predisposes then the patient to going into pulmonary edema frequently. So that's what's happened to my husband. And yes, we've had a bad 2 or 3 years, and now he's doing much better, wonderful, gaining weight and all the rest. Ejection, that's what I just talked about. It is the ability of the muscle to eject the blood that it needs to do. In other words, the ability percentage of this muscle to eject the 60 to 80 mLs of blood that it's supposed to. If it can't, and it's down in the 50% range or in the 30% range, that means this muscle is injured quite a bit, where just the normal amount of blood that comes in there, it's going to have difficulty giving it enough force on that contraction to empty its chamber. Does that make sense? Ejection fraction. They don't usually ask you about that, but they now have a test that they do send the patient in for, and this does come back showing heart failure, and we give the patient diuretics for that. And that test is the BNP that it talks about here. This is a neurohormone. It's secreted by the heart in response to the ventricular expansion or that ventricular volume. When that high BNP comes back, it shows that the patient is probably in heart failure, and we need to get rid of that fluid or else take the chance that the ventricles are getting harmed even further. Somebody's is running out of power. Remaining 24 seconds, 23 seconds. It's that one. All right. Medications. If we know that heart failure is pump failure, pump ability, what drug did we talk about yesterday that will help the force and contractility of the myometrium? Digoxin. Exactly. Dig. Now, they don't usually use Dig anymore, but you may still be seeing it used. There's better drugs out there that they give the patient. But one of those drugs that you will have to be aware of is Dig. What are the side effects of digoxin? Does anyone know?
Digoxin toxicity.
Lowers your heart rate?
It lowers your heart rate. Is that what you had said?
I said toxicity.
Toxicity, most certainly. It can be toxic. When it's toxic, what does it do? It lowers your heart rate. It can also speed it up, but most of the time the questions are going to go with the lowering of the heart rate. That's why you take the apical pulse before you give Dig. So, Dig, toxicity. Toxicity is usually a decreased heart rate. The patient doesn't really realize that, or even if he does have, he or she, a decreased heart rate, what usually brings them into the doctor isn't because they're coming in saying, I have Dig toxicity. They're coming in because they are nauseated, they may have vomiting, and they have anorexia. They may have blurring of vision, double vision, diplopia, and they may have halos around lights that are sort of bluish in color. Maybe they come in because their heart's so slow and they have changes in their LOC. Now, LOC by itself does not tell me that that is Dig toxicity, because we know that LOC changes have to do with oxygen, correct? So it could mean a whole wealth of things. That's just one added sign and symptom down the road. But what do you think are the hallmark?
Blurry vision.
This, something to do with vision, and this especially. If they are Dig toxic, there are reasons for Dig toxicity. It could be that their potassium is low. If their potassium is low and they're complaining of this, you may suspect Dig toxicity also. And why would their potassium be low? Because they're on diuretics to get rid of all that extra fluid, right? And most diuretics decrease potassium, so they're on diuretics. There is an antidote now for Dig toxicity. We didn't used to have that way back when. We had to dialyze the patient in order to get rid of the Dig. That was our last resort. Now we can give Digifab. Digifab. Digifab is the antidote for dig toxicity. Now, you would have to do some research to find all this information, because it doesn't, in this book, give you that information all in one spot. You'd be reading along and find that. You'd find your signs and symptoms of dig toxicity all over the place. You'll find it in your NCLEX book. But for some reason, books don't put everything in order along the way. And because I know that there are questions out there going towards this, these are my notes off of my brain that I can tell you are questions out there about digoxin. And there is always going to be questions about dig, because it is used still quite a lot. We do use also ACE inhibitors. ACE inhibitors were your prill drugs. How did they work? We went over it yesterday. They block angiotensin 1 from becoming angiotensin 2. They decrease peripheral vascular resistance and improve cardiac output. Put that as another little note next to the prills. By decreasing angiotensin 2 from even developing, and we know that angiotensin 2 is a powerful vasoconstrictor, then in other words being used to state that, it states it in your book that it decreases peripheral vascular resistance. PVR. PVR is out in the body. Thusly, if we decrease that, then we're increasing and improving cardiac output. We also, due to left ventricular, we're going to give some beta blockers. Beta blockers, by slowing down the heart rate, also dilate. Beta blockers were what type of drug endings? OLOL. They work by slowing down the heart rate. Nursing interventions, heart rate and blood pressure charted before giving. The two beta blockers they like to give, and you need to know this, is Cardivol. No V in there, Cardilol. OLOL. And metoprolol. LOL. OLOL. Angiotensin 2 blockers. This means that we allow the renin to go all the way through. And it's after it's been changed into angiotensin 2 that we get the it's downstairs left-hand door.
Thank you.
Oh, potty? Does he have to go potty? Oh, well, whatever. Let him pee his pants. That's going to be your Cozar. These are your angiotensin receptor blockers. We haven't talked about those before, but you better get to know them. Those blockers are Cozar, Diovan, Avapro, They block the vasoconstriction, then the aldosterone secreting effects, and lead to vasodilation. Make up cards for this. It's about the best I can say. Neseritide. I think that other is, yeah. It's a drug for the human being natriuretic peptides. It's a drug that will work on the BNP to reduce management. Lower the oxygen requirements. Lower the oxygen requirements means that one of the ways that we can do that is by putting the head of the bed up. Minimum is 45, and if they still are short of breath, then it's high Fowler's. Head of the bed. Make a note on this. By increasing the head of the bed, you are decreasing the myocardial demand for oxygen.
Decreasing the myocardium
Demand
or oxygen.
for oxygen. By increasing the head of the bed to a semi-Fowler's or above, decreases the myocardial demand for oxygen. That's concept, it's an answer, but not asked that same way. What else is treatment? Edema and pulmonary congestion. There are things that we can do for that also. We give diuretics, we sodium restrict their diet, and we may have to restrict their fluid intake. You need to know that. The way we know that our treatment doing that is working is by doing daily weights. We've talked about the medicines, and it reiterates this to decrease the workload. We give DIG, we give ACE inhibitors, we give thiazides, we give loop diuretics, and when we are in fulminating heart failure, pulmonary, it's going to all be towards airway, maintaining airway and oxygenation. Nursing interventions. These patients are going to be on complete bed rest. You need to know that, you need to write it in. Complete bed rest means bedpan, no commode, no moving except for turning. They are in bed. Because they are in bed, what are they going to be at risk for?
Pulmonary edema.
Constipation late, but yes.
Pulmonary edema.
Pulmonary edema, that's going to be because of the heart failure.
clotting.
Yes, but what does the bed rest part? It's going to pool the blood. We're going to try and pool the blood. So they're going to be at risk for thrombophlebitis, DVTs, pulmonary embolisms then on top of that.
Fractures.
Long-term fractures, yes, long-term. Not for a few days though. Okay, for a few days if we're talking about that. So make sure that your questions are asking about the long-term effect and your short-term effect.
Pressure cells?
That can be long-term also, or within a day if you don't move them, yes. All of those. So we may see sequentials being put on their legs because they're really going to be at risk for that. And that's just going to demise them if we get a pulmonary embolus on top of heart failure. Monitor the vital signs. Watch on the urinary output and keep the legs elevated. You need to know those items that I just said. Auscultate their lungs. The dangerous part of anybody who comes in with heart failure. You may see some right, you don't see any left, but the danger part of just that diagnosis is going to be left-sided heart failure. Because we know left-sided heart failure is going to kill the patient because of the complication of pulmonary edema. That is a concept that you have to keep in your mind because there's going to be questions are going to be asked of your prioritizing and of your what are you going to do first. And the first thing I'm going to be doing is putting their head at the bed up, and I'm going to be getting vital signs and listening to lung sounds because as soon as I hear crackles, wheezes, anything that shows me it's lung, I am letting somebody know. This is concept. I don't know how to put it down on paper for you to understand that. But the answer is always going to be the fact that you are picking up on in heart failure that left-sided is a sound that they make in their lungs, or you see an increase in respiratory rate and it's now respiratory. It is an emergency. It needs to be taken care of now. The patient will die if you don't. DIG, toxicity underneath here. It does go over nausea, vomiting, anorexia, pulse below 60. Yes, they may have that headache, but they may have the blurred and color vision. Is most of the time a vision problem that they will put in there as a sign and symptom of toxicity. Diuretics, your thiazides are your hydrochlorothiazides, your hydrodiurils. Bumex, Lasix are your loop diuretics. Aldactone. Just the word aldactone makes you think of aldosterone. You know that aldosterone's job every day is to reabsorb sodium, which then reabsorbs water and gets rid of potassium. Knowing that, and that the other diuretics also get rid of potassium, we sometimes give a potassium-sparing diuretic. And that is going to be then your aldactone. Let me tell you though, aldactone doesn't work very good as a systemic getting rid of fluid. So they may use it in combination with other diuretics. Okay, just to try and keep some of it. Nitrates. Nitrates, when we give low, write this in. When we give low dose nitrates, it decreases the chance of tolerance. So we start off low dose rather than high dose, because there's only so much we can give. Once we hit the high dose, they're at a tolerated amount and it's not going to work.
It decreases the tolerance.
Tolerance is where you take a drug and it doesn't have the effect that you want it to have. You build up a tolerance sometimes to pain medicines, where it takes more pain medicine to get that same effect that you had the very first time you received Demerol 50. After getting 50 for so long and every 3 hours or whatever, sooner or later you're going to need to have 75 in order to get the effect that you got with 50. Tolerance. Key components of care: smoking, decreased smoking, anticoagulants, $339. Please read over your care plan. This gives you valuable information for knowing how to take care of the patient out in the field, but it also gives you information for what you need to know for tests. It's just that added little bit extra that they may not have put into what we've gone over. Guidelines for interventions with heart failure. Nasal cannula, semi-Fowlers, conservation of energy. I want you to know out of those, all of them, but I want you to know for the test, to monitor for signs of fluid and potassium imbalance. So you're going to be watching their urinary output. You're going to be watching their daily weights. I and O's. They do need to have nutritional intake. You need to know this. We usually restrict sodium to 1,500 milligrams per day, 1,500 milligrams per day.
Can you repeat that? You said 500 what?
1,500 milligrams per day of sodium. Water, we want to have the patient watch their water so that it's no more than 6 cups a day. That means 48 ounces a day.
Ms. Lee, where, are you on page 339, like the second?
Everyone's got that so far? All right, I want you to write this in also. If your patient is not compliant with these instructions, you need to find out by collecting information to identify the reason behind it. You just don't let them continue being non-compliant. So, if your patient is not compliant, find out by collecting information to identify the reason. The last box here goes over heart failure, and it's just in an outline form as to everything that we've talked about. We've talked about weight gain, we've talked about shortness of breath, we've talked about orthopnea, we've talked about swelling of the ankles, persistent cough, frequent nighttime urination, maybe not so much, but that may be a sign also that if your patient complains of getting up a lot at nighttime to go pee, they've got overfluid. And thank God they've got kidneys that are trying to keep up with it when they're lying down flat at nighttime. Also, the eating of meals, the low-fat diet, the small frequent meals. We talked yesterday about not eating big meals because that can bring on the possibility of an MI because all the circulatory blood goes to the gut to absorb nutrients. So we eat, anytime there's a nutrient question, the answer is probably going to be serve or eat small frequent meals.